Well, welcome once again for coming to this session. My name is Sergio Aguilar-Gaxiola, and I'm a professor of clinical internal medicine at UC Davis in the Department of Internal Medicine. And I'm also the founding director of the Center for Reducing Health Disparities. And the presentation is going to be about what are health disparities. And I want to thank you for coming to this session. And let me start with a question related to health disparities of information that I hope that you are familiar with. But if not, I'm sure that actually I'm hoping that by the end of this presentation, you are going to be familiar with this and as well as other information related to health disparities. Did you know that ethnically and culturally diverse populations receive less preventive care, receive lower quality of health care, also experience more adverse outcomes and die earlier than whites? All of this illustrates the issues of health disparities. But there is a little bit, there is information that is much more focused and more detailed about health disparities, like whites are 4 times more likely than African Americans to get coronary artery bypass grafting. People who suffer from angina or coronary heart disease. Also, older Asian American women have the highest suicide rate of all women over age 65 in the US. Also, African Americans and Latinos receive less pain medication than whites for long bone fractures, such as the femur, as well as other long bones. And Latino women suffer the highest rate of invasive cervical cancer and are 4 more likely to die of this cancer than white populations as well. And here in California, something that, when it comes to patients coming to for services, we have a large proportion who are non-English speaking. And there is quite a bit of research that has been done with these populations. And we know that they are more likely to receive care in emergency rooms. There are some populations like Latinos that often come to the doors of service when they are falling apart, and sometimes when things are very complicated for them as well. And also they receive less than optimal health care, less preventive care as well. These are some of the challenges with diverse populations. Increased risk of experiencing medical errors. So miscommunications in the clinical encounter are between providers and patients is an issue as well. Have fewer physician visits, less likely to be back and return for follow-up visits. In Latino populations, for example, those who get into services, up to 75% don't return for a second time. And one is left to wonder as to what might have happened in that first visit, what kind of experience they had that leads them not to return for a second time. And also they are less satisfied with healthcare. Well, all of these examples pinpoint to issues of health disparities. If this is an area that you are interested in and captures your imagination, there is a report that I would like to recommend to you that really started a national debate on the importance of health disparities here in the US. And the report is called Unequal Treatment. It's a report by the Institute of Medicine. And how many of you know about the Institute of Medicine? Have heard about it? Okay. If the medical field is where you are either practicing or you are hoping to get into, my strong recommendation is that you get into the Institute of Medicine and look at the reports related to medicine. This is one of the oldest institutions in the US, over 100 years, and is one of the most trusted sources for information that is very relevant and very timely. Congress very often uses the Institute of Medicine by requesting reports on information that is needed in the nation, but not only here in the US, but abroad as well. So the Institute of Medicine usually brings the best scientists in the nation and abroad to study certain conditions. Well, the Institute of Medicine back in 2002, they released this report titled Unequal Treatment, and it triggered a very important national debate that hasn't stopped since then. In fact, it really brought so much needed attention to the issue of disparities. And one of the findings that they reported was that the existence of health disparities was uncontroversial, unequivocal. And they found disparities in all of these conditions and areas that you see on the board here. Cardiac care, cancer screening and treatment, diabetes management, all the way to pediatric care, mental health, and surgical procedures, and many other conditions that are not included in this list. But I already started talking about disparities or healthcare disparities. So if I may ask you, what do you think are, when we talk about disparities, what comes to mind? What are the associations that you make?
Culture.
Culture, okay. Yeah, it's related to it. Any other, pardon?
Socioeconomics.
Socioeconomic status, yes. Anything else?
Geographical location.
Geographical location, yeah. All of those are factors related to disparities. But I'm going to share with you one of the most common definitions of disparities, which is this one here, and are differences. And basically, disparities refer to differences between Group A and Group B and Group C. But when we talk about health disparities or healthcare disparities, are differences in rates of disease incidence, prevalence, morbidity, mortality, or survival. Okay, this is a definition coming from the federal government. And also, disparities are differences in access to, utilization of, and quality of care, in healthcare outcomes, like, for example, disparities that were reported in the IOM unequal treatment report, like groups that suffer from severe diabetes with vascular complications, that African Americans tend to have more amputations of their legs than other groups, like the white counterparts, for example. So outcomes are related also to disparities, and also the environment. And this is something that I will be back to talk more about it in the context of the notion of the determinants of health. So this is an example of health disparities. This is percentages of adults age 18 to 64 without health insurance by race and ethnicity. And as you can see here, both Hispanics as well as Blacks tend to have the highest rates of uninsurance, okay, lack of insurance. But this is a little bit more complicated, actually, because there are groups that if you disaggregate them, like Latinos, or by whether they are immigrants or non-immigrants, these insurance rates are even more pronounced. For example, the immigrant Latinos, about 55% are with no insurance, they lack insurance coverage. So there are, once again, differences in any outcome that you can possibly think about. This is another example. This is that the more than 40% of low-income adults are unable to afford enough food. And what this graph illustrates is that African Americans, as well as Latinos and American Indian and Alaskan natives, way over 40%, they are unable to afford enough food. This is another disparity. Something that I would like to focus is that the word disparity has been increasingly replaced by the word equity, and I personally think that is good that this is happening, because the notion of equity is more in the positive than disparities. Disparities is more in the negative, whereas equity is more on the positive. And but equity refers to a system of fairness. Like, for example, all people have full and equal access to opportunities that enable them to attain their full potential. Equity in healthcare requires that resources allocation and access to healthcare be determined by the health needs. So depending on the health needs, the level of health needs, then the response ought to be related to that level of need. I'm going to illustrate a little bit more later in the presentation with another slide that I have related to this notion. So what is inequity? Well, there are differences that are systematic, there are pattern, and they are unfair. And by the most part, these differences can be prevented, can be avoided, if there is enough will to address these differences and make changes to them. Once again, this is the Unequal Treatment Institute of Medicine report that, as I told you, demonstrated that there is a substantial racial and ethnic variation in quality of health care. This report is on quality of care. It's not on access to care, but it really triggered a national debate that has continued until the present time. So one of the questions is, can we explain why disparities are created? Well, this issue of disparities is a complicated issue, because there are several factors at work that give as a result, health disparities. There is not a number one suspect or number one solution. Actually, it tends to be the confluence of different factors that give disparities as a result. One thing that is important to mention also is that, especially at the present time, there is this idea that we are not blaming institutions or people. It is more than anything the focus on solutions. What is it that we can do in order to overcome these disparities? And the existence of racial, ethnic, cultural, sexual orientation disparities does not imply that providers, in the case of systems of care, that they are intentionally producing these disparities. So this is an important piece. There are three levels that I would like to share with you that contribute to disparities. The first level is at the provider level, and it's related to what happens in the clinical encounter between the provider and the patients that give as a result differences in the quality of care that is provided. One example that I include here is this notion of stereotyping, because one of the questions that was at the heart of the Institute of Medicine report was, how is it that a well-intentioned provider that really has the best interest of the health of patients at heart, that produces unintentional disparities. And one of the issues that is addressed and is described in the report is the issue of stereotyping, which is a very human inclination that all of us tend to do when we are faced with complicated situations, that we tend to take shortcuts. And based on impressions, we tend to make conclusions, sometimes in the first few seconds when we see someone. For example, there are studies that show that in the first 30 seconds in clinical encounters that providers form a certain idea about the patient based on the appearance of the patient. Okay, so and this is related once again to this notion of stereotyping. But there are other things like clinical decision making. I already discussed with you, the disparity of African Americans having more amputations when they are faced with complications of their diabetes, the vascular complications, than other ethnic groups. And it has to do with the decision making that providers sometimes make. The other one is related to communications. There are significant medical errors that happen in the clinical encounters based on the quality of the communication that happens between the provider and the patient. And that leads to safety issues and medical mistakes. Another level is at the health system. And here, two examples are the complex systems for limited English proficient patients. I already gave you some examples about that, and also delays in accessing care. And the other level is at the patient level. And something that happens there is distrust or mistrust of patients. And this sometimes works in a way in which there are populations who are known not to access or seek medical care until they are falling apart almost literally. There are other things that are not necessarily related to disparities, like, for example, patient preferences. If a patient prefers to use the informal sector, for example, the informal providers, like folk healers or shamans, in certain populations, well, that is preferential, as opposed to disparities that are caused by the systems or by entities as well. There are different ways of understanding health disparities. One of them is a public health approach, which is the one that I will illustrate here. There are three different areas or dimensions that you can keep in mind as you try to understand health disparities. One is the social determinants, or even a broader category, which is determinants of health. Another one is interventions, and another one is outcomes. In terms of social determinants, these are some examples, like poverty. You mentioned the socioeconomic status as it relates to disparities. Well, poverty is very well known, or the socioeconomic status level, very well known to associate with less access to care, an impact on productivity, for example, and in a way that it becomes kind of a vicious cycle. Poverty, less access to care, more severe course in the disorder and the disease, and then the negative impact in terms of productivity, which leads itself to less income, and there it goes. But things like education, access to care, stress, physical status, all of these are examples of social determinants. Also in interventions, these are some of the interventions that are found to be useful, like doing surveillance and research. Now with the Ebola crisis, these issues of monitoring, in this case, the Ebola cases, is of critical importance to try to avoid, not only the spreading of the condition, but also disparities that may be caused in this relationship to this tremendous public health problem. Social support, community-defined approaches, issues related to policy and the public health information and dissemination, and also cultural competency programs. Also, issues related to outcomes. And some examples are morbidity, mortality, the level of functioning, well-being, resilience, as well as others. And something that I want to share with you is that we can try to measure many things related to disparities. What I want to illustrate here is that if you have certain inputs like equipment, skills, materials, times, and then you do evaluation research, evaluate certain programs that gives, as a result, new knowledge, new skills, new techniques, that in turn, it may lead to changes in policy, changes in practice, and then finally, having an impact on health benefits and economic benefits. But what I want to emphasize is that this has to be evaluated, and we can try to measure all of these things in this sequence of different stages of the evaluation. I want to emphasize that health equity is not only about race and ethnicity or language. There are many other factors in which disparities occur. One of them is what happens with older adults, which is an age group with unique needs that, there is some neglect. In our center, we recently finished an evaluation here in California of a public investment called the Mental Health Services Act that has over $10 billion invested in expanding the mental health services. And we were asked to evaluate this public health investment in reducing mental health disparities. And we look at 10 years of data and to look at the trends. And what we reported is that the age group that has had the less access to care in this, we reported about 9 years. It was the older adults. But this is just one illustration of other disparities that had been reported with this age group. Also, the LGBT community with access to adequate care, higher rates of smoking, alcohol and drug use, suicide and depression also. And also, as you mentioned, the geographic location, people who live in the rural areas, that they tend to have less access to healthcare professionals, especially specialty care, but also higher poverty levels, not only in the rural areas, but also in suburban areas as well, in relationship to urban areas. So, but enough about problems with healthcare disparities. I would like now to share with you some possible solutions to health disparities. This is a initiative that the AAMC launched along with other other associations like the American Hospital Association, and it's a national call to action to eliminate healthcare disparities. And what I would like to focus on is that they are calling for what this strategic imperative in which addressing disparities is no longer just about morality, ethics, and social justice, but to really move into a system of accountability for improving community health and population health. And they recommend very simple steps, 3 steps that would lead to significant impact. As you can see, one of them is to improve the data collection and the use of that data by collecting systematically race, ethnicity, and preferred language, as well as sexual orientation and gender identity data. Also, cultural competency, because if there are disparities in diverse populations and also by language, that has to, be related to how to improve the communication with the providers. There are some data, for example, in Latinos that indicate that up to 75% of Latinos, I think that I mentioned to you, when they get into the doors of service, don't return for a second time. And we have much more than a suspicion that culture and language play a critical role. One has to think about what are the kind of experiences that people have in the first visit that don't lead them to follow up on their visits. So culture plays a critical role. But the other one is the realization that positions of leadership and governance tend not to be that diverse, and that more diversity needs to be represented in these positions in order to make changes. Also, the Affordable Care Act has addressed issues of health disparities, and the most important one is, increasing medical coverage. I remember a year ago that I was in this conference when healthcare reform was about to be implemented, and it was just a few days after, the tremendous fiasco that happened with the website. You may remember that, in which there were so many complaints that and for a good reason, because the website wasn't working, and but it caused so much turmoil, and look what has happened since then. Those problems were addressed, and now we have about 10 million newly insured, and with a good proportion of those newly insured coming from California. I think that nationwide, we are in a totally different place than we were a year ago, just a year ago, in terms of addressing issues of insurance coverage and access to care. And this is having an impact on reducing disparities or achieving health equity. Yes?
I think it's 1.5 million who are now insured in California.
What?
1.5 million
Yeah.
in California.
Right.
Insurance.
Right. And counting. This will continue in this, in the new year. There's going to be another cycle of actively enrolling people, both in medical as well as in Covered California. And it would be interesting to see how much we can move the needle, continue to move the needle. But thank you so much for that information. There are numerous provisions in the ACA that address reducing health disparities and increasing healthcare equity. Actually, there are 6 domains that are included in the ACA, One is, as I mentioned, the consistent data collection, also addressing workforce diversity, cultural competence training and education, providing funding for health disparities research, prevention. This is one of the key areas in the Affordable Care Act. You know, the issue about providing preventive services as part of the essential benefits, like screening for cancer through mammographies, for example, or through Papa Nicolaus in cervical cancer, or depression screening as well. You know, looking for different conditions that if we were to know about them in a timely basis, a lot of problems can be prevented. Also addressing disparities in health insurance reform. This is something that we are doing here at UC Davis in the medical center. Our center, the center that I direct, endeavor to systematically collect race, ethnicity, and language information as a way of achieving equity and quality of care. And these are some of the things that we did. We started back in 2007, and actually 2006, at the end of 2006. And the idea was to create ethnicity, race, and preferred language data fields in the electronic health records. And we did it through publicizing this initiative and informing patients, staff, and community. We did quite a bit of training, especially of the staff, on explaining why and how we were going to do that. Also on the categories that we were addressing, on something that we call REAL for short, you know, race, ethnicity, and language. And also on how to address concerns from the patients, because it was anticipated, and we had the experience that very few patients actually, it was less than some anticipated, were asking, why are you asking me these questions? You know, and the providers needed to be trained on how to best respond to that. The idea was to create reports stratified by ethnicity, race, and preferred language, and to associate those factors by indicators of quality of care as a way of creating what we call equity dashboards or equity reports, you know, by service or even at the level of providers as well. So this is one of the boards that was at one point deployed in many of the clinical sites across UC Davis, both the medical center as well as the primary care network in the outpatient care. And this is the big message that we were sending. We are asking because we care. Because there has been research in terms of what would be the best argument to provide to patients when you are asking this kind of information, you know, race, ethnicity, and preferred language. And the research indicated that when you use a quality of care argument by saying, we ask because we really want to improve the quality of care, that people tend to agree with that. And that's the message that we send. We have this poster board on some languages, and depending upon the services and where these were going to be you know, seen by diverse populations. And this is what we had been hoping for, is to identify and measure disparities in the delivery of healthcare at our health system, to monitor trends and changes in disparities, and by doing that, to create equity dashboards, and eventually is to achieve equity in quality of care across the variables that I've been discussing with you. And truly is to you know, put a mirror in our faces and see what kind of disparities we are creating. And more than anything is how we are going to solve, how we are going to approach changing those disparities. And the spirit is to really not to play gotcha, you know, is more than anything is as a way of, you know, self-reflection as to how these things are playing out, and more than anything to provide solutions for these issues. So let me ask you this question. Is it possible to improve community mental health by focusing primarily in access to care? You said no. Anybody else? Okay. Well,
marginally at least.
Marginally, yeah. I think that you both are right. And let me share with you some information related to this. This is related to the notion of determinants of health. How many of you have heard about the determinants of health? Wow, that's great. Very good. This is a paper written by Steven Schroeder, a colleague from UC San Francisco. A fantastic paper. You know, I would be willing to trade some of the papers that many of the papers that I have published by this paper. You know, I wish to have written this paper because it's just terrific. And there is this quote in the paper that I really like, and reads, even if the entire US population had access to excellent medical care, which it does not, only a small fraction of these deaths could be prevented. The single greatest opportunity to improve health and reduce premature deaths lies in personal behavior. In fact, behavioral causes account for nearly 40% of all deaths in the United States. And this is to illustrate in a more, graphic manner why just focusing on access to care is not enough in order to keep people from getting sick or to avoid premature death. Because as you see on the little hub there, you know, only 10% for preventing premature death is related to healthcare. Only 10%. 40%, this big hub there is on personal behaviors or behavioral factors. You know, even environmental and social factors captures a bigger share than having access to the best quality of care. So this realization really leads us to train medical students and to train residents in a different way. It is not only not enough anymore to just train the best possible doctors, but to train doctors with a conscience and doctors who are able to connect the dots, you know, and look at the big schema of things. And basically, one of the challenges is to train health professionals who are leaders themselves. And this is one of the things that I have a tremendous hope for this conference, you know, with this incredible, convening that brings about 8,000 this year, 8,000 participants. So this is just an illustration of why the determinants of health are of critical importance. This is a board created by the California Endowment here in California. The California Endowment is the largest health-related foundation in California. And what it illustrates is these two zip codes, the one on the left in which the life expectancy is about 72, and the one on the right is 86. Anyone has an idea where these two zip codes are from? Maybe some of you are from that area, those areas. Well, the one on the left is on East LA, okay? And the one on the right is in Palo Alto, okay? And there are 14 years of difference in life expectancy, the average life expectancy. But you know, there are some cities in which just a mile of distance, you can see these tremendous differences. And I don't know if you know, but the single strongest predictor of life expectancy is where do you live. Your zip code determines to a great extent how many years on average you are going to live. And this is the power of the social determinants of health. So that's why I think that is so important that we broaden the training of health professionals, not only to do the best possible job in the wonderful profession that is to provide services, the best possible quality services, but that it goes well beyond that. This is an action model that was included in Healthy People 2020. This is this organization nationwide that every 10 years come up with goals, health-related goals for the nation in order to keep a healthy nation. And they came up with a model that for the first time, they identified the determinants of health. And then also, they identified outcomes, health equity as one of the outcomes. For a good reason, once again. We have, like never before, information that we cannot ignore anymore, related to the powerful impact of poverty, for example, and where people live and where people work and where people grow up. This is from Healthy People 2020. What they did is this new focus on social determinants of health, that is, once again, of critical importance. I really like this illustration. And this is the difference between equity versus equality. In equality, the purpose is related to sameness. And if you take a look here, coming up with the similar intervention is not enough. It has to be related to the needs, as it is illustrated in equity, in order to have access to certain outcomes. Of course, here, the metaphor is to look at the ball game, and that there are different levels of need in different populations. Well, that is what health equity is about. So I have just 3 more slides. In conclusion, just healthcare disparities are, uncontroversial. They exist. They are a major public health problem at all levels, local, state, national, international. They also lead to significant burden of unmet health needs. This translates into a series of negative consequences like prolonged suffering, premature death, diminished productivity, and social and economic disparities. And we need to understand better the effect that social and economic determinants have on health and do something about it. So what is it that you can do about this? There are some, these are just some ideas, is to, as you become more aware of the existence of disparities and equity, that you spread the word, that you roll up your sleeves and do something about it, get to know the evidence, and also join the collective, will to tackle disparities and be determined to reduce them and eliminate them, and also to support innovative research to identify and deal with social determinants. How can you get involved? This is what this conference is about. There are many things that you can possibly do. You can get involved in research, to do it in clinical settings, and with clinical work, in community work as well, to do it at the policy level. and to volunteer. This is a conference that I think that I have been doing this for 10 years. And is one of the events that I wait year after year. And the reason is that I have seen results. For example, in the last couple of years, now we have medical students at UC Davis that were sitting where you're sitting, and now they are in medical school. And I have seen even some students at that time, undergraduate students in their 4th year, that already just graduated from medical school. So it matters, having this information and put it to use matters, and having you actively involved in these things is gonna, my hope is that it's gonna have an impact in your career, because you are our future. I would love to see you down the road as my colleagues, and know that you are looking at the big picture. You are looking at the determinants of health, and you are contributing to make this a better world. So with this, if you have any questions, I would love to hear from you. Any questions or comments? Yes?
It seems like with the advent of the Affordable Care Act that you have, and I could be mistaken, but it seems like you have a lot more Medicaid or California Medi-Cal recipients, and with the same number or less providers. How do you see the medical community as a whole adjusting to make sure that the quality of care of the underinsured doesn't increase because of this change?
Yeah, that's a wonderful, wonderful question, and one of the biggest challenges that we have, and let me tell you why. You mentioned that there is 1.5 million newly insured here in California, and the newly insured actually are very diverse populations. The majority are Latinos, and a good proportion of them are Spanish-speaking only. And as we had been seeing, having a medical card, or proof of insurance, or being under Cover California, the health exchange, it doesn't necessarily mean that folks are going to have access to care, actually, especially specialty care. So there is and we know that there are some physicians that are not ready to accept medical patients or Medicaid patients. And knowing also that the newly insured through Medi-Cal, these are populations that never had been insured before, and that they tend to be, with significant comorbidities, meaning, having physical conditions, chronic conditions, with mental health issues, along with substance abuse issues. It is like the, triple whammy of comorbidities. At the same time, we have a significant physician shortage here in California. I don't know if you have it in your radar, but by next year, the estimation is that we're going to have 17,000 physicians short. And yet, our medical schools, and we have 10 here in California, we are graduating about 1,400 new physicians every year for a population that is almost 40 million people. So we have a lot of work to do. But I personally think that, and the other challenge is that in the next 5 years, it is anticipated here in California that about 40% of the physician workforce is going to retire. These are the baby boomers. So the situation is dire. It's tremendous challenges. So I think that one of the solutions is that we need to expand the scope of practice. That when we talk about primary care, it is not just physicians that we're talking about, that family doctors or internal medicine or OBGYNs or pediatricians, etc. But we are also talking about nurses and social workers and even promotoras, or community health workers. And depending upon the level of need, we ought to be, much more strategic on how we met the needs of the needy population. We ought to also be innovative, like one of the big issues in some populations is access to care. It is people living in the rural areas, 3 hours or 6 hours even distance from where they can get the specialty care. So telehealth and telemedicine, those kind of technologies, and now that more and more those technologies are at the are available to us at a lower cost, and this is going to continue. So I think that we need to come from different angles, and also to think out of the box. There are still large proportions of groups here in California and nationwide that still, even with the Affordable Care Act, won't continue to have access to care. And we need to deal with that, whether we want to or not. And I think that is, and I'm thinking from a public health perspective, how do we keep the populations that are here in the US as healthy as possible? Because if we don't, we run the risk of multiple issues. And I can think of tuberculosis, I can think of HIV, I can think of conditions, health conditions that we need to be responsive and tackle that. So that's one of the areas. So I think that in response to your question, it has to come from different angles. There is not a single a single solution, but there are things that are being done already, and if we do it in a systematic manner, I think that some of the challenges of your wonderful question can be at least to provide partial solutions. Thank you. Yeah, you have another question?
The new program you're implementing at the UC Davis Center where you work, when you do identify health disparities, how will you go about addressing them from a behavioral standpoint, given the fact that personal behavior has such a big impact on health disparities?
Yeah. There are, one of the focus of our center is, I think that I mentioned, is to come up with solutions to the problems. And just to give you an example, there are counties, specific counties that have come to us for assistance in terms of how to help them solve some of the disparities that they are facing. We're working right now with Ventura County, Tulare County, and with Solano County. And with different, depending upon the needs that they have, we are hoping to come up with joint solutions with them. For example, Tulare County came, the Director of Public Health and Behavioral Health came to ask us if we can help them create an infrastructure, primarily to face, to look at the health of the newly insured. They have 4,000 newly insured through what was called the low-income health plan, which is now Medi-Cal. And they know that this is a very needy population. They haven't been insured before, and they have multiple health needs, very complicated cases with multiple comorbidities. So the challenge there is how we can help with that. And we had been down to Tulare County to do focus groups with providers and community leaders, but also with patients, to try to find out what matters to them. What is it that their needs are, so we can come up with joint solutions and to ask for funding, federal funding. So that is to Larry. We are now working also with Solano County, and they came to us, similar case. And what they want us to help with is what they call cultural transformation for the health system of care. And to do it with developing a model that is innovative. And what we are doing is a combination of training their personnel at the same time as we train community leaders, CEOs of CBOs, and to train them along with their with the leadership of these systems in the culturally and linguistically appropriate service standards, the class standards. This is a training that we developed at our center. Took us 5 years to develop and to pilot test it. And we have a training of about 16 hours that is designed for the leaders of the health systems. So what we are intending to do with them is to train at the same time the leaders of Solano County Health Services, and especially mental health services, along with the leaders of CBOs, as well as community leaders at the same time. And to hear from them what matters to them, and to come up with the specific action plans that they can tackle a specific 15 standards, class standards, and so they can select one or more of those standards to implement in their area. But at the same time, we are looking at the social determinants of health. Solano County is asking us to focus on 2 populations that have documented health disparities, specifically mental health disparities, and that is Filipinos and Latinos, and to come up with preventive measures. So what we're thinking about is to look at youth violence prevention, because I don't know if you have it in your radar, the strongest prediction of early onset mental illness, and at the same time, early onset of premature aging and premature death, is childhood adversities. People who have experienced in their lives any kind of adversities, any kind of abuse, sexual, physical, mental, or emotional, or domestic violence, or experiencing, alcoholism in the family, or suicide in the family, or severe mental illness, or extreme neglect. All of these things are strongly related. It's the strongest predictor of early onset mental illness, and also the early onset chronic health conditions. So it is a combination of looking at how to transform the services that they provide by learning directly from patients, the target populations that they have, Latinos and Filipinos, as to what matters to them. And to try to, through this training that we're hoping to do with them, is to try to come up with action plans that would be more responsive to their target populations, but at the same time, to work on the front end. So we address the issue of, fail first, fail and then you go for services, and to do it as early as possible, to intervene as early as possible in order to prevent from getting into, into problems. So it is we're hoping to come up with a innovative model that hopefully is going to be implemented, and if it works. And by the way, all of this is related to outcomes. And the outcomes that we're hoping to link it to is better experience of care, satisfaction with healthcare, outcomes, very specific outcomes like, the use of emergency services, or hospitalization, how that is reduced, and also reduce costs. These three specific outcomes are called the triple aim that the nation is pretty much seem to be enamored with. Very good. Okay, well, thank you so much once again.